welcome, Dr. Specks. We're so privileged and happy to have you here today.
Well, thank you for the invitation, and it's a pleasure again to host or participate in this webinar. We've had live meetings in the past, and we're slowly returning to those. And in the meantime, I think these webinars serve a great function because they reach a lot more patients that may not be able to travel. So there's a great role for these, and I hope that I can enlighten people about respiratory symptoms in vasculitis and how we approach them as in a diagnostic fashion as a pulmonologist. And I hope that I can provide some clarity about the terminology that is used and about the tests that we use to get to the bottom of respiratory or pulmonary symptoms and problems in vasculitis patients. To be specific, we will start out with reviewing respiratory symptoms in vasculitis patients and try to figure out what we're really talking about, because sometimes words are used that may mean different things to physicians compared to patients. So some clarity here will be provided. We will then dive into the various possible causes of shortness of breath in vasculitis patients, and that will take the form of a little 101 crash course in physiology, explaining all the components of the respiratory system or all organ systems that, if there's something wrong, can lead to the sensation of shortness of breath on the part of the patient. And then we will review the various methods that your physicians may use to find out why you're experiencing shortness of breath. And this really encapsulates the various components of a systematic diagnostic evaluation for a patient with respiratory symptoms in the setting of vasculitis. So let's talk a little bit about words we use. So when we're talking about shortness of breath, we as physicians often use a term that is a Latin term for this that's called dyspnea. So shortness of breath at rest or shortness of breath with exertion. And we often specify this: is this occurring when you're walking? Is this occurring when you're walking uphill? Is it occurring when you walk up a flight of stairs? And that will tell us a little bit about how severe it is and also how it has changed over time in your particular situation. Now, very often we ask additional questions to clarify whether what you mean when you talk about shortness of breath is really what we as physicians understand when we hear the word shortness of breath, because very often the questions will lead to the understanding that what we're talking about may not be really shortness of breath, but it may be more fatigue, or it may be related to weakness. And sorting out these nuances in the initial interview with your doctor is very, very important. Second most frequent symptom of the respiratory system that is related by patients is cough. And cough can be dry or hacking or not producing any phlegm, or it can be productive of phlegm, and then we ask you about the color and the amount, and et cetera, because that can tell us something about the nature and the origin of the cough. And when you're coughing up blood, then we use the term hemoptysis, or you may find that term used in your medical record when you review it online, as most of the patients have access to the online medical records these days. So cough with or without phlegm, cough with or without blood. And then there is another often used symptom that is called wheezing. And wheezing is usually something we as doctors hear when we put our stethoscope on your back and have you breathe. And then we hear wheezing with the stethoscope, and that's the wheezing of asthmatics. And that's the wheezing that is very common in EGPA, or formerly known Church-Strauss syndrome. Now, sometimes we hear the patient describe wheezing and they say, I hear it, or even the relative sitting next door or next to them say, yeah, we hear the patient wheeze. And that is often not true wheezing, but it is actually a noise that is made in the airway due to narrowing of the airway. And it's most common in patients who have subglottic narrowing due to GPA. And that is actually not wheezing, but we use the term stridor for that. So what are potential causes of respiratory symptoms in vasculitis patients? Well, they can be caused by the active disease, the active inflammation affecting the airways, the lungs, the heart, the kidneys, or the vascular system. And I'll show you how that is possible. So not everything that makes you short of breath is due to problems in the lungs or the airways, but it can be related to problems with the heart or even problems with the kidney or the vascular system. Now, active disease can cause problems with breathing, but also when you're in remission, damage from past disease or damage from treatment can also cause respiratory symptoms. And this distinction of respiratory symptoms caused by active disease versus respiratory symptoms caused by damage is very important because the treatment consequences are very different. Active disease, we try to treat with better immunologic therapies or immunosuppressive therapies that control disease activity. But damage will not be affected by more immunosuppression. Actually, more immunosuppression can cause more damage. So we want to really identify what is causing the shortness of breath. So if it is a scarring in the airway due to narrowing of the airway, or the other way around, narrowing of the airway due to scarring, when the active disease is well controlled, immunosuppression doesn't help, but that requires a dilatation procedure, for instance. And I'll show you some slides on how that is done. Treatment complications can lead to respiratory symptoms, and most commonly, these are infections. And rarely, there are some of the drugs that we use to treat vasculitis that may occasionally have some side effects in the lung that then can cause shortness of breath. And then, of course, there's a whole host of other problems that can lead to shortness of breath or other problems, particularly undetected obstructive sleep apnea, which can lead to high blood pressure in the pulmonary circulation. And we go over that briefly too. Now, I already alluded to the fact that shortness of breath can be caused by a variety of problems in other organs. And when we list them here in simple order of various tests that we can look at to identify where the problem is, we have to think of several things. So first of all, we look with a blood test for anemia. Anemia can be caused by chronic kidney disease, by bleeding, by blood loss through the GI tract, iron deficiency. A whole host of reasons can lead to anemia, and anemia is very common in patients with vasculitis. And when you're anemic, you're short of breath when you move. So we need to see, do you have anemia, yes or no? And if it is yes, then we need to find out what the actual cause of the anemia is so we can correct it. If you have heart failure, the symptom is shortness of breath. So we very often take a look at your heart with an echocardiogram to make sure that there is no heart failure. Or we do a blood test that is often abnormal in patients who have heart failure. That's called the NT-proBNP. It's just a blood test that looks for heart failure. Then, the airways, if they're narrowed, already mentioned that, we can lead to shortness of breath, and we use pulmonary function testing to find out whether there is airway narrowing. The pulmonary function test, as well as imaging studies, tell us whether there is something wrong with the lung tissue. If there is a problem with the pulmonary vessels, either through blood clots or through pulmonary hypertension, we can find that out again with a variety of tests, the first one being an echocardiogram. Sometimes, if you have nerve problems, the respiratory muscles can be weakened as a result of that. And again, we have some breathing tests that point in that direction, and the pulmonary function test will allow us to detect whether there are respiratory muscle problems. Now, kidney, I already mentioned that, can lead to anemia, but kidney function impairment can also lead to fluid overload, which can then back up in the lungs and impair the gas exchange and make you short of breath. And finally, and last not least, after you've been very ill for a long period of time, you will have lost a lot of your normal muscle strength, and you will be very deconditioned after a chronic illness. And then every effort is much harder until you have been able to slowly build back the muscle mass and the endurance and the conditioning. So recovering from a chronic illness is often an uphill battle. And part of this battling and regaining the conditioning requires an exercise program. And as part of that exercise, then you will initially feel short of breath, but ultimately you will be able to do more with less shortness of breath as you get better and reconditioned. So there's a lot of issues that can make you short of breath, and they need to be addressed in a systematic fashion. So this slide may be a little bit complicated, but it really shows you how this all ties together. So in essence, in order to not feel short of breath, your tissues, shown here on the right side, the body tissues, they need to get enough oxygen. If they get enough oxygen, they're happy, they can function well, they signal to the brain, everything's okay, we can do stuff, and we're not fatigued. But if there is not enough oxygen being delivered, the organs cannot function well, and the brain gets the signal that you're short of breath or that you're weak, and you end up being fatigued. So how does the oxygen get out of the air into the tissues? Well, on the left side here, you see this little sac that symbolizes the small air sacs in the lung tissue, the delicate lung tissue. The oxygen gets into this airspace, and then the oxygen transitions through a very thin lining out of the airspace in the lung into the vascular space in the lung, where the oxygen that gets picked up by the red blood cells bound to hemoglobin and then transported by the heart over to the tissues, where it then gets released from the hemoglobin and diffuses into the tissue where it gets. So you can imagine that if there is a problem in the lungs, you have difficulties getting the oxygen where it ought to go. If you don't have enough of these red cells as carriers of the oxygen around, your tissues will not get enough oxygen and you will feel short of breath. If there's a problem with the vessels themselves, so that the blood supply doesn't flow freely, you can get into trouble with more shortness of breath. And if the heart, that is the big pump through all these systems of the blood, is weak, then again, shortness of breath is the result. So on this slide here, you see a normal chest röntgenogram on the right side, where in the center here you have your large airways, your trachea, your main stem bronchus, and here on the left side, you see this three-dimensional picture of the anatomy. And then you see this big shadow here, which is your heart. And so it's sitting right here in the chest. And then you have the lungs that are filled with air. And because there's air in them, they are black. And anything that's not filled with air that is denser is white. So your heart is white, your diaphragms are down here, and your belly is mostly solid stuff in there. So it's white, but the lungs are essentially translucent because they're filled with air. Now, chest röntgenogram is usually the first way we check the lungs. And on this slide here, I have a list of all the tests going from least invasive to most invasive that we usually do in a sequential order to get to the bottom of shortness of breath or low oxygen levels in the blood. So we start with a complete blood count to look at the hemoglobin. Then we do a chest röntgenogram or chest X-ray, which I just showed you an example of. And you'll see some more examples of chest CT scans, which give us more detail of the lung tissues and which will show us lesions or abnormalities that we often call spots or nodules. And if they're bigger, we talk about masses. And if they have a hole in them, we call them cavities. So I show you examples of that. And you had some questions submitted about what these lesions are. So I'll show you some examples. So then we move on to breathing test generally, which gives us a lot of information. And then we can get fancy in measuring your oxygen saturation in the blood at rest and with exertion, or with arterial blood gases. And then if we have more questions about your airways, we sometimes do a procedure that's called a bronchoscopy, and I show you how that is. And when we look at the heart, we do an echocardiogram, and if all of these tests don't give us the answer, we sometimes do a cardiopulmonary stress test or cardiopulmonary exercise study, and they usually can be done together. And then last not least, if we think about obstructive sleep apnea as a cause of fatigue, then we often do what's called a polysomnography or a sleep study. So these are the main diagnostic tests, and in various combinations. And with those, we're usually able to tell you why you're short of breath, whether there's anything wrong with your airways, your lungs, or your heart, or what we need to do to correct the problem. Okay, why am I stuck? I am stuck. Okay, now we're here. So again, X-rays and what we can see on chest imaging and on CAT scanning. So when you compare the previous chest X-ray and compare it to this one, you see there is more white stuff here than on the previous one that you saw, and this white stuff doesn't belong there. And when we do a horizontal cut through your chest with a computer tomogram or a CT scan or CAT scan, you see the corresponding section through your lung on the right side here. When we look at CAT scan images, imagine that we're standing at your feet and looking up to your head. So this is your right side, this is your left side, and this is your right side. And in the middle, we have your heart. Normal lung tissue looks like this black area up here. And this white stuff here all doesn't belong there. And in this case, this is actually blood that has filled the lungs in a patient with active vasculitis, either GPA or MPA, who has alveolar hemorrhage, bleeding into the alveoli of the lung. And that is an acutely life-threatening situation that needs to be treated quickly and definitively. Now, again, more CAT scan images. And when we look at the images on the left side first, on the left upper panel, you see a patient who has all these small round shadows or white spots. So sometimes they're referred to as white spots. We call them nodules because they're round and they're essentially horizontal cuts through little spheres. So these are round little balls in your lungs that are nodules, okay? And when we treat the patient adequately, they go away completely, like you see here on the right side in the same patient 6 months after treatment start. Another situation, a different patient on the left lower side here, sometimes these nodules are bigger. And when they get bigger and get access to an airway, the center that often contains what we call necrotic material or dead tissue because it hasn't gotten enough blood supply. If it has access to an airway, it can get coughed out, and then you have a hole in the middle, which we refer to as a cavity or cavitation. And here, same thing, there's a cavity or cavitation, and there is some liquid in this cavitation, so that's why you have this air fluid level. So this is a mass lesion with a cavity. This is a nodule, and this is larger than 3 centimeters, so it's also a mass with a cavity. Good thing is, after successful treatment, these resolve completely, and they may leave behind a tiny scar like this here, or this here. And these tiny scars are functionally not relevant. The rest of the lung is normal, and the lung function is back to normal. Even though these are big lesions initially, the lung function remains normal, and these lesions can essentially completely disappear, only to show a little scar there. So a word about lung function test or pulmonary function testing. So essentially, when you get to a lung function test, you do a more modern version of this old drawing from Netter, but the principle is the same. We have you breathe in a tube, and you breathing through this tube will result in some changes of other tubes that then lead to a recording of lung volumes. So essentially, we have you breathe in and out of a tube, and we get a recording of that. And these lung function test does several things. It gives us numbers about the various volumes of the lung, how much you can breathe in and out, how much air is in your lungs, how much air is in your chest, and that can tell us about lung tissue loss as well as respiratory muscle weakness. We can measure your airflow, how much you can breathe in and out in a certain time frame, and that gives us an indication of whether there is any airway obstruction. And it allows us to tell us where that airway obstruction is. Is it the small airways or is it the large airways? We can have you do a maneuver that's called bugle pressures, where we essentially measure how much pressure you're able to generate breathing in and how much pressure you're able to generate breathing out. And this is a marker for how strong your respiratory muscles are. Now, we also get numbers about your oxygen saturation and whether it is adequate or reduced at rest or with exertion. And that tells us whether you may need any oxygen supplementation, either at rest or not at rest, but with exertion. And then finally, we get a number that's referred to as the diffusing capacity, which is a measure of the gas exchange, how well the oxygen can travel from the airspace into the bloodstream. And that tells us something about the lung tissue, but also something about the lung vessels. So here's an example of a test result, and it's all these numbers. Again, lung volumes, flows, diffusing capacity, oxygen saturation. But I want to draw your attention here to the shape of the expiratory flow volume loop in this patient. So the shape should normally be like this large dotted line. And the shape here is reduced, so less flow. and it has this kind of almost like a lawn chair shape where it goes up and then it comes down, but then there's an elongated expiratory phase. And this is typical for airway obstruction. And in this case, in the context of asthma, and this was a patient with EGPA and just some peripheral infiltrate again in the lung. And this is eosinophilic pneumonia in a patient with EGPA who has asthma with this typical pulmonary function test result of asthma. Now, moving on from breathing tests to looking into the airways. So if the breathing test doesn't give us all the answer and the chest imaging doesn't give us all the answer, or if we, for instance, want to find out where the patient is bleeding from, or if the lung function has given us an indication that there is a narrowing somewhere in the large airways, we may take a bronchoscope and go into this airway with the bronchoscope under anesthesia and see where there is a problem that is caused by GPA or more rarely MPA or other forms of vasculitis. And we can also use this bronchoscope to get some samples from the more distal airways to look for infections or to look for blood and other potential markers. So the bronchoscope is used to inspect the airways, to sample fluid out of the airways, sometimes to do a little biopsy, and it can also be used to dilate some narrowed portions of the airways. So here are some examples of what we can see with the bronchoscope looking into your airway. So here is you see this red stuff here where right under your vocal cords, this is the so-called subglottic area, the part of the trachea, big windpipe right under your vocal cords, and it's actively inflamed. So that's active disease, but there is no narrowing of the airway. So this is not causing shortness of breath at that moment, but it is actively inflamed and it needs to be treated. Now, after treatment, sometimes this can scar down, and then the scar is actually leading to more shortness of breath, and this is damage from the disease after the inflammation has been adequately controlled. And this narrow airway needs to be opened up again, and this is generally done with an ENT procedure, dilatation procedure, and restoring the patency of this airway. But this will not respond to more immunosuppressive therapy. I'll spare you these further curves, but this patient with the narrowing had, flattening of the expiratory flow volume loop and flattening of the inspiratory flow volume loop. So a pulmonary function test tells us what the nature of the airway obstruction is. This is a lesion further down in the airway, so you have a narrowing of a segmental airway. And as a result, there is obstruction, and sometimes infections can occur because there is no normal airflow and no normal getting rid of bacteria through these narrowed airways, and this can lead to a so-called post-obstructive pneumonia. Bleeding into the lungs, we already talked about. We can skip over this, but what we do usually use with a bronchoscope when we see something like this, we want to know, is this blood in the lungs or is this just a bad pneumonia? And sometimes we need the bronchoscope to go into the lungs and to find out whether there is an infection or whether there's blood. And if there is blood, we will get bloodier return, one after the other of what we get out. And then we know this is alveolar hemorrhage in the context of active disease. Now, sometimes treatment complications can cause trouble in the lungs, and most notoriously, the patients who are immunosuppressed are prone to get infections, and these can be bacterial, mycobacterial, fungal, or viral. And again, the bronchoscopy with BAL can often help us get material to identify the infection. And very rarely we have drug toxicities. We don't use cyclophosphamide or Cytoxan hardly ever anymore, so we don't encounter much of that problem anymore. And methotrexate very rarely causes problems in the lungs. I've seen maybe 4 or 5 cases of that over the course of my career. So fortunately, this is a very rare complication of methotrexate therapy. Most patients who are on methotrexate will never have any problem of lung toxicity. So high blood pressure in the pulmonary circulation, again, this is often a problem. We can identify this with a variety of tests. We think about it when the gas exchange measure, the diffusing capacity is low on the breathing test. We then get an echocardiogram that allows us to estimate the pressure in the pulmonary circulation. And then if that is abnormal, we sometimes need to do a right heart catheterization to get true numbers. And when there is pulmonary hypertension, we have treatments for this. So we need to think about it, we need to look for it, and then if we find it and quantify it, we have treatments for it. Now, pulmonary hypertension can be caused in vasculitis patients in a variety of different ways. So patients with ANCA-associated vasculitis can have deep venous thrombosis and pulmonary embolism during the acute phase, and that can sometimes lead to pulmonary hypertension. Patients with Takayasu's arteritis can sometimes have vascular narrowing in the pulmonary vessels and remodeling of the pulmonary vessels, causing pulmonary hypertension, high blood pressure in the pulmonary circulation. And that needs to be looked for because you don't see it on the typical chest imaging studies. You need to think about it and then do an echocardiogram and potentially other heart tests to find it. It can also be caused, pulmonary hypertension can also be caused when there are low oxygen levels in the blood at night when patients sleep. And that is very often caused by obstructive sleep apnea, which can also lead to daytime fatigue. And obstructive sleep apnea can often be brought out by prednisone treatment, which, as you may know, can change the thickness of the neck and the inside of the oral cavity, and it can lead to obstruction of the oropharynx that then translates into obstructive sleep apnea. So we often need to look for that and test for that, particularly if patients have changed their weight and their neck structure and their facial structure as a result of prednisone therapy. Blood clot, we can skip over this. He shows a very big blood clot in the central pulmonary arteries. That's life-threatening. What we see more often are smaller blood clots that are sitting out more in the periphery of the lung, and they can occasionally cause a small portion of the lung tissue to die off. It's called a pulmonary infarct that can also lead to a small lesion on the CAT scan that can look like this. It has a little bit of a trapezoid form, and that's not to be mistaken with disease activity in the lung. Obstructive sleep apnea symptoms are morning headache, daytime sleepiness, loss of libido, bad dreams, snoring, and apneic spells that are often witnessed by the bed partner. And this is caused by choking on the tongue, so to speak, because the tongue falls back when you're relaxed and it occludes the airway. A screening test for this is a test called overnight oximetry. Essentially, a pulse oximeter is put on your finger and it's hooked up to a recorder that measures your oxygen saturation at night. And that can give us a telltale sign for obstructive sleep apnea. And if there are telltale signs on this very simple test, then we generally recommend a complete sleep study. So if you have sleep apnea, CPAP can turn your life around. There are other treatments nowadays in addition to CPAP if you don't tolerate CPAP, but the sleep doctors can tell you much more about that. So in summary, there are many reasons for the respiratory symptoms in vasculitis patients. causes of these need to be determined in an organized fashion, and active disease needs to be differentiated from damage and from treatment complications, as all of these can lead to abnormal chest imaging studies, to respiratory symptoms ranging from shortness of breath to cough, to low oxygen levels in the blood. And we need to identify reversible and treatable causes of these symptoms so that we can treat them appropriately. And with that, I'd like to switch to the questions, and I hope we have enough time for going through the questions that were submitted, and then maybe answer a few more questions that were submitted in the chat box.
Well, we will do our very best. That was a fabulous presentation, Dr. Specks. I feel like so many things were answered in that presentation. I'll get started with some questions if you're ready. I think the comments we're getting is that it's been an awesome presentation so far, so we appreciate that.